Good morning, good afternoon, and good evening all. A very warm welcome on behalf of the IAPB events team. We're very much looking forward to supporting you with today's Strengthening Capacities and Technical Acumen webinar series, with today's webinar focusing on diabetic retinopathy. I'm now delighted to hand over to Prut to welcome you to the webinar today. Thank you very much.
Thank you. Thank you. Good afternoon and welcome everybody to the webinar session, Strengthening Capacities and Technical Acumen on Diabetic Retinopathy. This webinar is hosted by IAPB and WHO. Next slide, please. This is the map made by the International Diabetic Foundation, and they keep renew the map almost every year. And this is to show you that the number of patients who have diabetes mellitus and diabetic retinopathy is increasing in every part of the world, and the rate of increasing is rapid. Next slide, please. The objective of this session is to familiarize the stakeholders with the screening and operational guidelines recently developed by the Southeast Asia Diabetic Retinopathy Expert Group. This is a booklet. You can find it anywhere. Next, please. And in the session, we will have 4 speakers speaking on the epidemiology, pathogenesis, and clinical feature of diabetic retinopathy. And the next is investigating patients with diabetic retinopathy. Next will be management and referral guidelines for diabetic retinopathy. And the last speaking is planning, management and evaluation of diabetic retinopathy screening program in Southeast Asia region. And after the 4 topics, we will have panel discussion from the expert in our region. Next slide, please. Next, I'm going to introduce our speaker. This is me. I'm Dr. Prut Hanusaha, visual retinal surgeon working in Ramathibodi Hospital in Bangkok, Thailand. Next, please. And we will have renowned speakers. First is Dr. R. Rajalaxmi, she is head medical retina in Dr. Mohan Diabetic Specialty Centers and in Madras, India. The next is Dr. Suganeshwari Ganesan. She is senior consultant in Sankara Nethraya Visual Retinal Oncology Service, India. Next, please. And the next is Dr. Rohan Chawla, Associate Professor in Rajendra Prasad Center of Ophthalmology Science, India. And our last speaker is Dr. Padmaja Rani. She is visual retinal surgeon from LV Prasad Eye Institute, India. And after the 4 talks, we will have a panel discussion from our panelists. Next slide, please. And our panelist comes from the expert in our region. The first one is Dr. Rabatapa from Nepal. The next is Dr. Tariq Reza Ali from Bangladesh. Next, please. And Dr. Abdullah Junat from Maldives and Dr. Paisan Romvibulsuk from Thailand. So not to waste the time, I would like to invite the first speaker to give the talk on the epidemiology, please.
Good day to all. I will be providing an introduction to diabetic retinopathy. During this session, we will be discussing about the burden, pathogenesis, classification, and clinical features of diabetic retinopathy and the associated risk factors. Diabetes is the single most important metabolic disorder affecting almost every organ in the human body. Chronic hyperglycemia is associated with long-term damage, dysfunction, and failure of various organs, especially the eyes, kidneys, nerves, heart, and the blood vessels. The chronic complications of diabetes can be divided into microvascular complications and the macrovascular complications. The microvascular complications are those which affect the smaller blood vessels. The macrovascular complications are those which affect the larger blood vessels. The microvascular complications include retinopathy, nephropathy, and neuropathy, while the macrovascular complications include cerebrovascular disease, cardiovascular disease, and peripheral vascular disease. Diabetic retinopathy is the most common morbid microvascular complication of diabetes. It occurs in both type 1 and type 2 diabetes. It is caused by prolonged uncontrolled hyperglycemia. Here you can see the images of a normal retina, the macula and the optic disc, and this is the image of diabetic retinopathy with vitreous hemorrhage. The estimated lifetime risk of developing diabetic retinopathy is 90% in people with type 1 diabetes and 60% in people with type 2 diabetes. Sight-threatening diabetic retinopathy is defined as presence of diabetic macular edema or proliferative diabetic retinopathy. Diabetic retinopathy is the most important cause of preventable blindness. Early detection and timely treatment of sight-threatening diabetic retinopathy can reduce the risk of visual loss by 90%. The burden of diabetes and its complications is on the rise. The International Diabetes Federation has estimated that in 2019, 463 million people with diabetes are living worldwide. With increasing prevalence of diabetes that is reaching pandemic proportions, there is a concomitant increase in the prevalence of diabetic retinopathy. It is projected that globally by the year 2040, there will be over 640 million people with diabetes, and roughly one-third of them will have diabetic retinopathy. That is, over 220 million people will have diabetic retinopathy, and one-third of those with diabetic retinopathy will have sight-threatening diabetic retinopathy. That is, over 70 million people will have sight-threatening DR. The meta-analysis of various studies of an estimated 285 million people with diabetes done worldwide has shown that the global prevalence of diabetic retinopathy is about 35%. There are about 93 million people with diabetic retinopathy worldwide and about 28 million people who have sight-threatening diabetic retinopathy. That is, approximately 1 in 3 people living with diabetes will have some form of diabetic retinopathy, and 1 in 10 will have sight-threatening diabetic retinopathy. The WHO Southeast Asian region consists of 11 countries, and it's already home to over a quarter of the world's population, and it has an estimated 96 million people living with diabetes. The meta-analysis done earlier has shown that the diabetic retinopathy prevalence is least among South Asians, roughly around 19%. This means that 1 out of 5 people with diabetes in Southeast Asia can have retinopathy. So let us try to understand the biochemical mechanisms associated with diabetic retinopathy. The 4 major biochemical pathways have been hypothesized to explain about the mechanism of diabetic eye diseases. This all starts due to hyperglycemia that causes vascular injury. The 4 main mechanisms are enhanced glucose reflex through polyol pathway, increased intracellular formation of advanced glycation end products, activation of protein kinase C, stimulation of hexosamine pathway. This leads to oxidative stress, formation of reactive oxygen species, and causing vascular damage. And this endothelial dysfunction leads to the development of diabetic retinopathy. The main pathogenesis of diabetic retinopathy is that it is a microangiopathy that affects the precapillary arterioles, it affects the capillaries and the venules. What happens in diabetic retinopathy? There is basement membrane thickening, endothelial cell damage, loss of pericytes, deformed RBCs and clumping, increased platelet aggregation, and increased thickness of the platelets that occurs in the retinal capillaries. This leads on to microvascular leakage and microvascular occlusion as shown in this figure. To expand and explain more about the pathogenesis of diabetic retinopathy, basically there is loss of pericytes leads to distension of the weak capillary walls and produces leaking microaneurysms. The inner blood-retinal barrier breaks down and it causes retinal edema as well as formation of hard exudates. The capillary occlusion then occurs as a result of platelets and leukocyte activation and addition to the abnormal endothelium. This results in retinal ischemia, hypoxia, which releases the vascular endothelial growth factor or the VEGF. This leads on to the formation of new blood vessels as well as it also increases the vascular permeability. Diabetic retinopathy can be detected by fundus examination by an ophthalmologist or by the physician by ophthalmoscopy. Of course, these days it is easier to examine using fundus photography. Retinal photography is equivalent or superior to ophthalmic examination for detection of retinopathy and to document the diabetic retinopathy lesions. Digital, mydriatic, or non-mydriatic fundus photography is a practical option to screen people with diabetes for retinopathy. Fundus photography has also paved way for teleophthalmology-based remote screening for diabetic retinopathy. How do we classify diabetic retinopathy? The early treatment diabetic retinopathy scale or the ETDRS scale, which is based on the modified Ehrlichhausen's classification, is the gold standard for grading of diabetic retinopathy, and it is used for various studies and clinical trials. But however, this ETDRS classification is cumbersome to use in clinical practice. The International Clinical Classification of Diabetic Retinopathy is the currently used diabetic retinopathy classification. There are 5 scales based on the severity and based on the findings on ophthalmoscopy. The first level is no retinopathy, where there are no abnormalities, and the second level is mild diabetic retinopathy with only microaneurysms. The third and fourth are moderate and severe NPDR, about which we'll be seeing in the next slides. And the fifth level is proliferative diabetic retinopathy, characterized by the growth of abnormal new vessels in the retina. So diabetic retinopathy is broadly classified as non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. Non-proliferative diabetic retinopathy is further classified as mild diabetic retinopathy characterized by presence of microaneurysms. Moderate non-proliferative diabetic retinopathy has additional lesions like intraretinal hemorrhages, cotton wool spots, hard exudates, etc. Diabetic retinopathy lesions are still reversible in the initial stages of mild and moderate non-proliferative diabetic retinopathy with good glycemic control. Progressive capillary non-perfusion is accompanied by development of increased numbers of cotton wool spots, venous beading, and development of intraretinal microvascular abnormalities. And this leads on to the progression to severe NPDR. Severe NPDR is characterized by at least one of the following features being present and is defined as the 4:2:1 rule. Presence of at least more than 20 intraretinal hemorrhages in 4 quadrants, venous beading, looping, or reduplication in 2 or more quadrants, or presence of a definitive IRMA in at least 1 quadrant. If 2 of the above features are present, it is called very severe NPDR. In PDR, the neovascularization can be present at the disc, which is called the NVD, or it can be present elsewhere, which is called the NVE. A preretinal hemorrhage, which is a pocket of blood which forms in the potential space between the retina and the posterior hyaloid phase, appears in a boat shape as shown here in this figure. Hemorrhage, which then goes into the vitreous, is called as a vitreous hemorrhage, and it appears as a diffuse hemorrhage or it appears as clumps of blood clots inside the vitreous gel. PDR can be classified as early PDR or as high-risk PDR when there are extensive fibrous proliferance with preretinal and vitreous hemorrhage as shown in this figure. Diabetic macular edema. Diabetic macular edema is defined as retinal thickening at or within 1 disc diameter of the center of the macula with the presence of definitive hard exudates or retinal thickening in the center at the macula. It is one of the most important causes of visual loss in diabetes. According to the Wilkinson's International Clinical Classification of Diabetic Macular Edema, diabetic macular edema is classified as mild, moderate, or severe DME. When the retinal thickening or hard exudates are away from the center of the macula, but at the posterior pole, it is called mild. When the retinal thickening or hard exudates are approaching the center of the macula, but not involving the center, it is called moderate DME. When the retinal thickening or hard exudates are involving the center of the macula, it is called severe DME. Diabetic macular edema can be categorized as clinically significant macular edema by the ETDRS classification if there is retinal thickening or hard exudates within the central 500 microns of the fovea. This is one of the leading causes of visual loss in diabetes. Diabetic macular edema can be classified as center involving DME or non-center involving DME based on the optical coherence tomography picture. You can see that this is a center involving DME and this is a non-center involving DME. The ophthalmologists find it useful to plan treatment based on the OCT-based classification. What are the symptoms that a patient with diabetic retinopathy will have? Diabetic retinopathy has a very long asymptomatic phase. Very often, there are no symptoms or visual disturbances in the early stages of diabetic retinopathy. When life-threatening diabetic retinopathy sets in, patients may have symptoms like floaters, blurred vision, distorted vision. Sometimes, even patients with sight-threatening retinopathy may not have symptoms and may even have normal visual acuity as seen in this picture. This patient with the diabetic macular edema with hard exudates at the posterior pole is completely asymptomatic. And here in this picture also, you can see new vessels very close to the macula, but the vision is normal without any complaints. But later on, with increasing severity of diabetic macular edema or proliferative diabetic retinopathy, they start becoming symptomatic, developing floaters and other complaints. How does the vision get affected in people with diabetic retinopathy? In diabetic macular edema, the visual acuity can be impaired in center involving DME or in clinically significant macular edema, or if the patient has vitreomacular traction or in the presence of macular ischemia. In proliferative diabetic retinopathy, the vision is affected due to the development of vitreous hemorrhage, tractional retinal detachment, neovascular glaucoma, or due to optic atrophy in advanced diabetic eye disease. The onset and progression of diabetic retinopathy is very often influenced by many systemic factors. The major consistent risk factors for diabetic retinopathy reported from various epidemiological studies include the duration of diabetes, uncontrolled hyperglycemia, hypertension, hyperlipidemia, and presence of associated diabetic kidney disease, anemia, and pregnancy. Of this, the most important non-modifiable risk factor associated with diabetic retinopathy is the duration of diabetes. The most important modifiable risk factors associated with diabetic retinopathy include hyperglycemia, hypertension, and dyslipidemia. Control of these risk factors becomes important in preventing development and progression of diabetic retinopathy. Thank you. This is a presentation from Madras Diabetes Research Foundation for the World Health Organization. For any queries, kindly contact us at the above email IDs.
Greetings everyone. Today we will be discussing about investigating patients with diabetic retinopathy. How do we investigate? When we want to confirm our findings, or when we are in doubt, or when we want to quantify or measure, when we require serial follow-ups, or when we have to educate our patients. Which modality to choose? So this would depend on the clarity of the media. So if the media is clear, one may decide to choose fundus photography, fundus fluorescein angiography, optical coherence tomography, or OCT angiography. If the media is hazy, then ultrasonography would be the choice of investigation. Fundus photography, most easily performed, widely performed, and it requires very least technical expertise. So one may decide to choose a 30-degree fundus photography or the 55-degree fundus photography and recreate the 7-field standard fundus photography. That is called a montage. If we want to study in depth or understand our patient's pathology in depth, then one should do fundus fluorescein angiography. Fundus fluorescein angiography is an invasive test. So there are certain parameters which we have to monitor. A blood sugar level being less than 200 milligrams and a blood pressure level being less than 160/90 and previous history of any allergy to fluorescein dye or a patient with a deranged renal function test should not be subjected for a fundus fluorescein angiography. And the last oral intake has to be 2 hours prior to the schedule of injection. And most important, we have to obtain a verbal consent and a written consent signed by the patient and the witness. The patient has to undergo dilatation of the pupil and the dye has to be injected in the antecubital vein in a rapid flush of a 3 cc of 20% fluorescein or a 5 cc of 10% fluorescein, and then the patient's images are taken serially. And being an invasive test, it does have its own set of anaphylactic reactions also. These reactions can be as mild as the pruritus, or it can be as severe as bronchospasm, laryngeal edema, or even cardiac arrest. So this test has to be performed with the presence of an intensivist or an anesthetist. Now moving on into the phases of a fundus fluorescein angiogram. So what do? So once the dye is injected, we see interchoroidal circulation, which is seen as choroidal flush, and then it moves on into the arterial circulation, retinal vessels, where we see in the arterial phase, and then moving on into the early arteriovenous phase, the mid arteriovenous phase, and the late phases. So these are the phases of FFA. And the fluorescence is seen as normal fluorescence or abnormal fluorescence. So when we have abnormal fluorescence, it is described as hypofluorescence or hyperfluorescence. So if it is hypofluorescence, then it is either as blocked hypofluorescence or a vascular filling defect. And a hyperfluorescence is seen as leakage, pooling, or staining. FFA is preferably performed only in patients with a good media clarity. But there is one exception to the rule. What is that? That is asteroid hyalosis. So in a patient with asteroid hyalosis, though the media is not clear, but still FFA would give you the best understanding of the disease. And what are the other indications? So to identify microaneurysms for focal treatment, and if there is presence of macular ischemia, it can be picked up on an angiogram. Or to differentiate between severe non-proliferative diabetic retinopathy from proliferative diabetic retinopathy, and to identify coexisting vascular occlusions, or to pick up the high-risk characteristics. Now, when we have a patient with a succinate pattern of hard exudates, then the corresponding angiogram will show a focal patchy leakage. So this is called a focal diabetic macular edema, which is amenable to focal laser treatment. Most common cause for drop in vision in diabetic patients are the diffuse macular edema. So wherein we see the leakage in a petaloid pattern, this is called petaloid pooling, wherein the dye leaks into the cystic cavities of the fovea. So this is called diffuse diabetic macular edema. If the patient has a drop in the macular area, which is called as vascular filling defect, it is appreciated as area of hypofluorescence. So this is called macular ischemia, which is a very bad prognostic sign. Now, if the vessels are fragile, then they leak the fluorescein dye, which is seen to be progressively increasing over the phases of angiogram. So this is called neovascularization elsewhere. So if the same thing happens on the disc, then it is called neovascularization of the disc, which is again a global sign of ischemia. When the blood gets trapped in between the pre-retinal surface and the detached posterior hyaloid, it is called subhyaloid hemorrhage. When it is present in the macular area, it causes severe drop in vision. So this is seen as a blocked fluorescence. So that is what is appreciated here. Now, till now, what we have seen is the conventional angiogram, which is where you get the images. But when you get images more than 100 degrees of retinal surface, that is called ultra wide field fluorescein angiography, very useful for picking up the peripheral neovascularization and also the peripheral capillary dropout. And in patients with persistent macular edema, most of the times one may pick up peripheral capillary dropouts, which being the reason for the persistent macular edema. This is very useful in patients who are not so cooperative and in children. Now, to summarize, fundus fluorescein angiography, it's an invasive diagnostic modality used in clear media, provides insight into retinal and choroidal circulation, can be associated with anaphylactic reactions. Serial tests are to be avoided for 24 hours after angiography. The next modality in a clear media is optical coherence tomography. So in this, it picks up the non-invasive cross-sectional real-time images of the neurosensory retinal architecture by processing backscattered light. So an assessment of retinal thickness is possible and an assessment of response to therapy is possible. The most commonly investigated modality, or rather the structure, is the macula. Layers are the RPE, RNFL, ISOS junction, and the OS tips, whereas the low reflective layers are the nuclear layers. So what we see on the top panel is the time domain OCT. What we see on the bottom panel is the SSOCT. Now these are the structures which are identified in a diabetic patient. So what we see is the microaneurysm, which is seen on the top panel, is appreciated as a hyperreflective echo in the inner nuclear layer, and the hard exudate is seen as a hyperreflective in the outer plexiform layer, and a cottonwool spot is seen as a hyperreflective in the nerve fiber layer with a corresponding elevation of the internal limiting membrane. The other lesions in OCT are the spongiform thickening of the retina, which is appreciated like this, and the intraretinal cystoid formation. And here is a patient where you see with the serous retinal detachment and the cystoid formation in the intraretinal. A patient with diabetic macular edema, the top panels are amenable to medical treatment, that is a spongy edema, cystoid spaces, and the sensory detachment. The bottom panel is amenable only to surgical modality, that is a vitreomacular traction and the tractional retinal detachment. OCT is very helpful in picking up the poor prognostic markers. So when we see patients with disorganization of inner retinal layers, this is called as drill, and inner retinal hyperreflective. These are again poor prognostic markers, and the subfoveal hyperreflectivity, which we see here in the bottom panel, There's nothing but hard exudate at the fovea and a taut posterior hyaloid face and a subfoveal neurosensory detachment. And the last panel, which shows the loss of the ellipsoid layer, are all poor prognostic markers. But in OCT, we can also pick up the good prognostic markers. These are the bridging retinal processes, which suggest that there is still the existing communication between the neurosensory retina and the RPE. And the most commonly talked about central subfoveal thickness is only useful for assessment of serial follow-ups, but otherwise not a very useful investigation. Now, moving on into the latest, the OCT angiography, wherein one can perform or rather understand the retinal vessels without injecting a dye. So it is very useful in patients with renal impairment and allergy to fluorescein dye, and in pregnant mothers or patients who are breastfeeding, or in pediatric patients. The advantages: it is quick, non-invasive, gives layer by layer information, and the limitations are, until now it is only 12 millimeter scan is possible, which is in the step source of the, cannot detect microaneurysms, cannot identify areas of vascular leakage. So the neovascularization is seen as a tuft of vessels here, and the capillary non-perfusion is seen as flow voids. So this is an Octa image which shows the superficial capillary plexus, and we are seeing the neovascularization of the disc and the vitreoretinal interface lab, which shows the neovascularization. And here the structural OCT shows the breach in the ILM. This is the neovascularization of disc. To summarize the lesions in the diabetic patients, so you have microaneurysm, which are red lesions here, and which is seen as patchy hyperfluorescence, and the same one is seen as a hyperreflective in the inner nuclear layer. Now, hard exudate, which is seen as yellow lesion, block fluorescence, and seen as a hyperreflective in the outer plexiform layer. Cotton wool spot seen as white lesions on the fundus with a block fluorescence, and then seen as a hyperreflective with corresponding area of elevation in the ILM. So the neovascularization, which is seen as a breach in the ILM. So in summary, it is a non-invasive tool, uses light waves in infrared range, provides information on retinal architecture, qualitatively and quantitatively useful in surgical decision and in prognosticating outcomes. So what do we do in patients with a hazy media? We do ultrasonography. Ophthalmic ultrasound works on the principle of acoustic impedance, and it's indicated in patients with cornea opacity, hypema, non-dilating pupil, dense cataract, vitreous hemorrhage. So we evaluate the vitreous body. So if a fresh vitreous hemorrhage, it is seen as fine dot echoes. Old vitreous hemorrhage is seen as clump and membrane echoes. And when we have the posterior vitreous detachment, it is appreciated as the one what is seen here. So you see the posterior vitreous detachment, and then the echoes in the front, which are the vitreous hemorrhage, echoes behind, it's a subhilar hemorrhage. And we also can evaluate the retina. So if there is focal attachment with a posterior vitreous detachment, it is seen like this, and this is the ultrasound image. And if you have a tabletop detachment, this is what is seen on the ultrasound, and you have a detachment with multiple focal traction on the retina. This is what we appreciate. So this is useful in surgical decisions. In summary, ultrasound is useful. It's a non-invasive tool used in hazy media, provides information about posterior vitreous detachment status, presence of vitreous hemorrhage, and retinal integrity, helps in decision making and in planning of surgery. So all these investigations are very helpful in our decision making and planning of the management. So in a clear media, one would do a fundus photography, fluorescein angiography, optical coherence tomography, or optical coherence tomography angiography, or in a hazy media, ultrasonography. So the decision has to be made wisely. Thank you for allowing me to speak to you on this most useful topic. I would be happy if you have any queries. Please reach me at this mail ID. Thank you.
Hello everyone, I am Dr. Rohan Chawla, Associate Professor of Ophthalmology at Dr. RP Center, AIIMS. I shall be discussing management and referral guidelines of diabetic retinopathy. The first point of contact with the doctor for most patients with diabetes are physicians or endocrinologists. Thus, it is important that an appropriate screening protocol must be initiated by them prior to any fall in visual acuity, as this may occur later in the course of diabetic retinopathy, and by then the pathology might have significantly advanced. Referral involves identifying the eligible population, informing them about the possibility of developing diabetic retinopathy, screening or testing using appropriate technology, and timely referral. WHO has been regularly publishing guidelines for such referral. The aim of systematic diabetic retinopathy screening is to reduce the risk of vision impairment and blindness among asymptomatic or minimally symptomatic people with diabetes. This can be reduced through prompt identification and effective treatment of sight-threatening diabetic retinopathy. Patients with type 2 diabetes need to be seen at the time of diagnosis and every year thereafter if no diabetic retinopathy is detected. Patients with type 1 diabetes can be sent for an ophthalmic examination between 3 to 5 years after initial diagnosis. Puberty can exacerbate diabetic retinopathy, and thus if a child is attaining puberty, then an early referral is mandated. Pregnancy can also exacerbate diabetic retinopathy in a known case of diabetes. A retinal examination of these patients should be performed prior to pregnancy if feasible, and then every trimester. Patients developing gestational induced diabetes are at low risk of developing DR, and they may not be screened. Several tests are used for DR screening. In a setting where an ophthalmologist is directly conducting screening, indirect ophthalmoscopy and slit lamp biomicroscopy may be used, although these are likely to be uncommon in primary care setups in developing countries. In recent years, OCT has also been used for diabetic retinopathy screening in developed countries. The decision on which technique to use is not just dependent on the relative sensitivity and specificity of these tests, but also on issues like cost, ease of use, and type of health professionals available. Cost goes up from ophthalmoscopy to fundus imaging to OCT. However, there is a trend towards screening with a modality which can also capture an image, as this can also be analyzed by telemedicine and in future by artificial intelligence. Regardless of the test that is used, it is imperative that the person conducting the test and screening is adequately trained and certified. Now, there are many classifications that have been used to classify diabetic retinopathy, such as the Early-House and the ETDRS classification, but one of the most common used is that given by the International Classification of Diabetic Retinopathy and Diabetic Macular Edema. Similarly, diabetic macular edema has also been classified. If diabetic retinopathy is detected, then re-examination duration depends on the severity of diabetic retinopathy. The time between repeating screening tests is called the screening interval. Most studies conclude that the screening interval or frequency of rescreening should be between 1 and 2 years if no diabetic retinopathy is seen. In UK, the screening interval has been increased from 1 year to 2 years. Some physicians or optometrists might be using various devices to capture images. If you find symptoms or signs such as unexplained vision loss, hard exudates, and edema at the posterior pole, or neovascularization, then an early referral is advisable. Sudden visual loss merits an emergency referral. Now let us discuss steps to slow progression of diabetic retinopathy. Now, controlling the systemic parameters is one of the most important and often neglected aspects of managing diabetic retinopathy. A well-controlled diabetic and hypertensive is less likely to progress. Studies like DCCT and UKPDS have established that in both type 1 and type 2 diabetic patients, a 10% reduction in HbA1c approximately reduces risk of microvascular complications by 30 to 40%. Systolic and diastolic blood pressure have also been found to be independent risk factors for diabetic retinopathy progression. An HbA1c less than 7 and a blood pressure of less than 140 by 85 mm of mercury should be aimed for in these patients. Both the statin and fibrate group of drugs have also been found to reduce rate of diabetic retinopathy progression. An LDL level of less than 100 milligram per deciliter is perhaps a reasonable level to aim for. Additionally, use of these drugs have also shown to reduce hard exudates. ACE inhibitor use in early retinopathy can also reduce diabetic retinopathy progression. Hemoglobin level of less than 12 is also a risk factor for diabetic retinopathy, and there are other factors such as smoking and lack of exercise which can exacerbate diabetic retinopathy. Thus, quitting smoking and encouraging physical exercise is also an important aspect of our management. Assessment of disease severity requires various investigations. These have already been covered in a previous talk. So we shall now move on to management of diabetic retinopathy by ophthalmologists. Coming to managing PDR, that is proliferative diabetic retinopathy, in the absence of macular edema. Now, anti-VEGF therapy has dramatically altered management of diabetic retinopathy. However, still, currently for proliferative disease, the gold standard therapy remains pan-retinal photocoagulation. Diabetic retinopathy study has provided good evidence of its efficacy in reducing severe visual loss by 50%. Reassessment for need for laser augmentation is generally done at 4 weeks following laser. Anti-VEGF therapy at regular intervals has also recently been found to be non-inferior to pan-retinal photocoagulation. It has the added advantage of downgrading the level of diabetic retinopathy and possibly avoiding side effects of pan-retinal photocoagulation. But it has its own limitations, such as it can have a risk of endophthalmitis and repeated unending therapy, and the disease may progress to a very severe form of proliferative disease if the patient stops getting regular injections due to any reason. Since anti-VEGF therapy has an excellent effect on macular edema, combining anti-VEGF therapy with pan-retinal photocoagulation is a practical approach for cases of proliferative retinopathy with center involving macular edema. Now, this is an ultra-wide field fundus image showing the pan-retinal photocoagulation spots. Even in the presence of some vitreous hemorrhage, the visible retina should be lasered. Once the proliferative disease progresses to an advanced stage, such as developing vitreous hemorrhage, tractional retinal detachment, or extensive raised proliferation, then the case must be referred to a vitreoretinal surgeon, as the patient may benefit now from an early vitreoretinal surgical intervention. Coming to macular edema, OCT-based terminology is now preferred to the clinically defined CSME, which was given by ETDRS. For center involving macular edema, anti-VEGF therapy is again a game changer, as it is the only therapy which can actually lead to an improvement in vision. All anti-VEGF drugs are effective for macular edema, and the choice of drug largely depends on economics, availability, and legal issues. The response takes few weeks and is assessed by an increase in visual acuity and a change in the central subfield macular thickness on OCT. For non-responding or minimally responding cases, and those in which the edema rebounds every month or so, intravitreal steroids can also be considered as an option, provided risk factors such as glaucoma have been ruled out. These are OCT images showing macular edema prior to therapy and a marked reduction in the macular edema following anti-VEGF therapy. Non-center involving macular edema can still be managed with focal laser. This will be dealt with subsequently. A grid laser, which was the gold standard therapy for macular edema as per the ETDRS study, has now lost favor following anti-VEGF injection availability, but it can still be done in situations like cases with stubborn recalcitrant non-responsive macular edema or where intravitreal injections may not be feasible. And cases of tractional edema which do not show a good response to anti-VEGF therapy can be managed by vitrectomy. Now this image shows how a modified grid laser can be applied. Coming to non-center involving macular edema, targeting areas of focal leak away from fovea helps to reduce macular edema and hard exudates. The response is slow and may take 3 to 4 months. And this can always be supplemented by anti-VEGF therapy if edema progresses to involve the center. And vice versa, focal augmentation of laser can be done for a case of center involving macular edema when the central subfield macular thickness reduces significantly. Now here is an example where you can see these focal leaks on fluorescein angiography, but the OCT shows that the center does not have significant edema. And this case can be managed by applying focal laser to these areas of leak. Another example showing how focal laser can reduce macular edema and hard exudates. So this image is pre-laser showing a lot of hard exudates, and this is post-laser where you can make out that the number of hard exudates has significantly reduced. A recent study by drcr.net has shown that in presence of good vision, that is around 6/9 or more, there is no urgency to start anti-VEGF therapy even if central macular thickness is more than 300 microns. But some of these cases having otherwise marked retinopathy or poor control or a macular thickness of more than 400 microns may soon start losing vision and must be kept under close follow-up. To answer some queries regarding anti-VEGF therapy, regarding pregnancy, it is better avoided, especially in the first trimester. Following a stroke or a myocardial infarction, anti-VEGF therapy may hamper the normal systemic revascularization and thus should be avoided for a few months following such an event. Itself, intravitreal anti-VEGF therapy has not been shown to increase the incidence of stroke or MI as compared to a subset of population of the same age. Again, all anti-VEGFs are comparable, with probably the newer, more designer molecules giving better anatomical results. But the clinical relevance of the same yet needs to be fully understood. The interval of re-injection may be less in newer molecules which have a higher affinity for VEGF. But as I said, we still need more data on the actual clinical and economical implications of these facts. Now, intravitreal steroids can also be helpful in certain situations, such as pseudophakic patients who have normal discs and intraocular pressure. The duration of action of depot steroids is longer, and they may lead to better resolution of hard exudates and inflammatory markers represented by hyperreflective dots on OCT. Glaucoma and cataract are their major side effects, which may offset the visual gains from this intravitreal steroid therapy. Thus, they can always be used as primary therapy or adjunct to anti-VEGF therapy in managing macular edema in selected situations. Targeted laser photocoagulation involves lasing peripheral capillary non-perfusion areas with the aim of reducing macular edema at the center. It can be done in recalcitrant cases or where there is marked peripheral capillary non-perfusion. However, its efficacy and evidence of use is still not very conclusive. Subthreshold laser also holds good promise as it does not cause permanent damage to the retinal pigment epithelium and the overlying photoreceptors. However, again, we don't have very large studies to determine its actual utility. Patients with diabetes, especially a patient of diabetic retinopathy with cataract, must be managed with a properly thought out plan. It is always a better idea to treat and stabilize the retinopathy component with anti-VEGF or laser if such therapy is indicated, and this should be done prior to cataract surgery. Simultaneous cataract surgery with intravitreal injection can also be considered to prevent a rebound of edema after the cataract surgery. Multifocal intraocular lenses should largely be avoided in cases with significant retinopathy or macular edema, and it is well established that any surgical intervention is preferable if the diabetes is under good control. Now, these patients may also need additional referral for glaucoma management, as it is found to be more common in diabetics, and they can also develop retinal vascular occlusions and neuropathies, which would additionally require further specific management. To summarize, timely screening ensures an early diagnosis, and an emphasis on good systemic control definitely helps to slow the progression of retinopathy. Judicious use of anti-VEGF agents, focal or pan-retinal laser photocoagulation, and intravitreal steroids wherever indicated are the mainstays of therapy to prevent moderate to severe visual loss. Vitreoretinal surgery can be thought of in advanced cases, and there it may also help salvage vision. Thank you.
Hello, I'm Dr. Padmaja Kumari Rani. I'm vitreoretinal surgeon and head of teleophthalmology at the LV Prasad Eye Institute. Today, I will be discussing about planning, management, and evaluation of diabetic retinopathy screening programs in the Southeast Asian region. Planning diabetic retinopathy programs. How do I get screened for diabetes and diabetic retinopathy? When we look at top 10 health issues by World Health Organization, diabetes occupies fourth position. Diabetes mellitus is increasing in the world, and in countries of Southeast Asian region, the International Diabetes Federation estimates that the number of people with diabetes in 7 countries of Southeast Asian region is likely to increase from 87.6 million in 2019 to 115 million in 2030. Diabetic retinopathy is an important cause of vision impairment and blindness in Southeast Asia. The age-adjusted prevalence of diabetic retinopathy in Southeast Asian countries is likely to increase from 11.3% in 2019 to 12.2% in 2030. Let us look at the challenges in planning a diabetic retinopathy program and components of an ideal diabetic retinopathy screening model. When we look at challenges in diabetic retinopathy program, will be at 4 levels. That is at the level of disease of diabetes and diabetic retinopathy, at the community level, individual level, and healthcare provider level. It is very important to understand that all these challenges are interdependent as well. This slide shows an overview of challenges at all 4 levels. So challenges pertaining to the disease of diabetes, chronic status, high prevalence, more number of undetected, late detection, and with a variable modifiable risk factors such as glycemia and hypertension control, smoking, dyslipidemia, and non-modifiable risk factors like age, gender, and genotype. Diabetic retinopathy challenges no early signs and symptoms, vision loss is irreversible, and which requires a continuous treatment and follow-up, and treatment outcome depends on systemic control. Challenges at the community level are geographic distribution with access issues related to transport, cultural issues, and awareness. At the individual level, healthcare seeking behavior plays a very important role. An ideal diabetic eye care model should have a high yield of sight-threatening diabetic retinopathy with inbuilt components of customized awareness creation to the target communities. Should be cost-effective, sustainable, and should be able to support continuity of care with an inbuilt follow-up and referral system. The model should have components of capacity building, and there should be linkages, both vertical and horizontal, for the management of diabetes and DR at all levels, that is primary, secondary, and tertiary levels. Management of diabetic retinopathy programs. Screening strategies can be divided into population-based and opportunistic screening. In population-based screening, mass screening for diabetes and diabetic retinopathy is not recommended as it does not have high yield of disease for both DM and DR and not at all cost effective. Targeted screening of high-risk communities like people with more duration of diabetes, family history is more recommended option. However, Opportunity screening of people with diabetes for DR, especially above age of 40 years, is the ideal, sustainable, and cost-effective option. Linkages and partners play a crucial role in any diabetic retinopathy screening model. It is important to establish trained diabetes and hypertension educators at the community level. Partnership with non-governmental organizations like Lions Club International Foundation, Rotary are important. Involvement of technology partners like companies producing indigenous cost-effective fundus cameras, automated grading softwares for DR is very important. And appropriate vertical and horizontal linkages at all levels and integration with government health sector is necessary for universal screening coverage. Last but not least, collaboration and support from funding organizations like LCIF, World Diabetes Foundation, etc. are vital. When we look at the potential screeners who can screen for diabetic retinopathy, it can be both medical and paramedical personnel. They can use combination of screening modalities available like ophthalmoscopy and fundus imaging. Vision assessment can be done at all levels. Direct ophthalmoscopy can be done, but the sensitivity and specificity for detection of DR is low. Indirect ophthalmoscopy and fundus biomicroscopy can be performed by ophthalmologists and retina specialists in resource-limited settings. The gold standard is non-dilated or dilated fundus imaging for screening of diabetic retinopathy. The images can be acquired by technicians and the readings can be done at all levels with appropriate training to pick up DR and sight-threatening DR. This slide shows template for managing risk factors for diabetic retinopathy and screen models for DR in Southeast Asian region at primary, secondary, and tertiary healthcare levels. Desirable, recommended, and essential care levels for a particular country were chosen based on the availability of resources. Screening services that need to be established for diabetes eye care delivery include health education and identification of those at high risk can be done at all levels. Screening for DR and diabetic eye diseases, which includes refractive errors, cataract, and glaucoma, can be done at all levels. Screening at vision center should preferably have a facility to use non-mediatic fundus camera for retinal imaging. Blood sugar testing facility can be done at, again, all levels. Treatment of diabetic retinopathy in the form of lasers and intravitreal injections, screening for complications can be done at both secondary and tertiary levels. Follow-up, compliance to treatment, modifiable risk factor control can be ensured at all levels from community to tertiary level. The way forward for a diabetic retinopathy screening model is an internist or a physician-centered model. Why? Because physician is usually the first contact with the people with diabetes. In diabetic retinopathy, only 5 to 10% is sight-threatening or referable, whereas 90 to 95% of diabetic retinopathy management is modifiable risk factor modulation by the internist. It includes diabetes, hypertension, dyslipidemia control, lifestyle changes, and the key person is the physician. Fortunately, diabetic retinopathy is based on an image-based diagnosis, and identifying diabetic retinopathy by fundus photography is not a robotic science. Options of cost-effective non-mediatic fundus cameras are available. Fundus imaging tests should be part of various battery of investigations that are offered at an internist office. Ophthalmology targeting all preventable causes of blindness, including diabetic retinopathy, should be part of medical curriculum. A physician-centered model can bridge the gap between the research and practice. The reported metabolic memory theory clearly demonstrates that the good glucose control at the diagnosis of diabetes will have positive impact on microvascular complications like diabetic retinopathy later. whereas blood pressure control lacks metabolic memory and needs sustainable control for the management of diabetic retinopathy. Thus, an internist or a physician-based diabetic retinopathy screening model is a cost-effective opportunistic screening modality with preventive and holistic approach. Effectively, it can tackle up to 90% of burden of DR with only 5 to 10% of sight-threatening diabetic retinopathy will require referral to an ophthalmologist. Evaluation of diabetic retinopathy programs. Important indicators in the evaluation of DR programs include awareness, service delivery, and capacity building. Important indicators related to awareness creation is assessment of knowledge, attitude, and practice at regular intervals. Target for KAP studies should include all stakeholders from both community and healthcare providers of diabetes care and eye care. Service delivery indicators include number of people with diabetes screened for DR, proportion of people with diabetes who had DR screening, number of sight-threatening DR cases identified, cases treated by medical or surgical management, and number blind due to DR. Some more important indicators include percentage of annual increase in people with diabetes in an eye clinic, in follow-up patients with diabetes, and percentage of referrals from general practitioners and diabetologists. Various capacity building indicators include at the human resource level, the number of vision health guardians trained as diabetes and hypertension educators, physicians trained in diabetic retinopathy management and referral guidelines, ophthalmologists trained in medical management as well as surgical management of diabetic retinopathy. In the infrastructure, number of fundus imaging facilities available at primary, secondary, tertiary care and physician offices, number of laser treatment or intravitreal injection therapy facilities available, and number of surgical management of diabetic retinopathy facilities. Increased knowledge, attitude and practice of all stakeholders, and increased access to the services, adherence to the clinical advice in the form of increase in the uptake of services, with a desirable reduction of modifiable risk factor load in the form of prevalence of hypertension, smoking, or dyslipidemia showing a dip, with integration of diabetes eye care at the level of community and physician, finally will show the importance of effectiveness of a diabetic retinopathy model. Thank you.
Thank you very much. I would like to thank the 4 speakers to give us a very, very clear and informative talks. Next, we have about 25 minutes for discussion. And first, I would like to focus on the screening. Dr. Chawla and Dr. Rani has already talked a little bit on the screening, but we are in a big region. So first, I would like to ask Dr. Rabathapa from Nepal, can you please explain the DR screening system in Nepal? Are there any difference from the talk we listened before?
Thank you, Dr. Pruitt, and there were already a great presentation. I would like to congratulate the presenters. In Nepal, a diabetic retinopathy screening program is going on in various levels. In the primary eye care level, we have diabetic retinopathy screening by the allied ophthalmic personnel by training them on fundus photography. They screen in using fundus photographs, and also in some of the centers we have set tele-ophthalmology service where they send the pictures, and also we can communicate directly with the patient about their problem in community eye centers using allied ophthalmic personnel, and in hospital where diabetic retinopathy has been integrated as a comprehensive diabetes management in the physician endocrinologist clinic. Although these are limited, we have set a model, successful model, and these have already published in peer-reviewed journal, and where we have used allied medical personnel. They are the health personnel with training of 6 months training on diabetic retinopathy screening and fundus photography teaching. They are able to take fundus photographs and grading diabetic retinopathy, vision threatening retinopathy, and they work under the physician and endocrinologist, and they refer only sight-threatening diabetic retinopathy and also the referable retinopathy that we call it as a moderate NPDR and worse. So this is the second model. And third model is by the ophthalmologist in the secondary eye care center, secondary hospitals, eye hospitals, where the trained ophthalmologist, they do diabetic retinopathy screening using dilated fundus evaluation with the slit lamp and refer the sight-threatening retinopathy to the tertiary level where they need injection anti-VEGF or surgery, and they can also manage. We have trained them for the laser therapy, so the pan-retinal photocoagulation they can do by themselves. In some of the centers, although it is not a very widespread, we have to scale up this service, and definitely in the tertiary hospital where we have specialized vitreoretina specialist, where we mostly focus on the referral patient coming from the primary eye care center, from the physician clinic, and from the secondary hospital, where we treat with the various kinds of laser, focal laser, and pan-retinal photocoagulation. We provide treatment with anti-VEGF and with the vitreoretinal surgery wherever needed. The model has been going successfully, although we need a scale of this to cover the wider area.
Okay. May I ask Dr. Ali from Bangladesh, in your country, are the screening system the same or different from this?
Yeah, thank you, Dr. Pruitt, for asking me, and IAPB, I'm very much grateful for asking me here to come here. From the 4 presentations, the great presentations, what we have learned today, that the prevalence of diabetic retinopathy is increasing, and among the highest level, that is, India is the highest who is suffering from diabetes mellitus, and Pakistan is 5th, and Bangladesh is 7th in the whole world. So prevalence of diabetes is 8% in my country, and prevalence of diabetic retinopathy is 33%, and diabetic macular edema is 34%. And in India, it is similar, that is diabetes mellitus for 12%, and diabetic retinopathy is 18%, and diabetic macular edema is 29%. And what Dr. Rabha Thapa from Nepal, she narrated the scenario in Nepal. It is very similar in my country also. What is the difference? That is, we have 13,000 community clinics throughout the country. These community clinics, they are taking care of all the population, and per one, that is single community clinics, is designed to take care of 6,000 population. So in the community clinics, there is no provision for screening of diabetic retinopathy. But what we have made till now, we have 8 divisions in my country, but in 6 divisions, we have made 90 vision centers, which LV Prasad Institute and other centers in India, they are making. So similarly, 90 vision centers in 90 Thana or Upazila level we have made. And in these vision centers, we have fundus camera. And this fundus photographs 20 patients per day is being sent to 9 base hospitals throughout the country. Already 9 base hospitals have been made other than the tertiary eye care center. These 9 base hospitals will increase to, that is, to 20 in 2023, within 2023. This is our model. And 90 vision centers will increase to 200 vision centers by 2023. This is our goal. So in 9 base hospitals, we have the provision for color fundus photography, FFA, OCT, and also laser. These 9 base hospitals, they have trained manpower who can do the laser. So if needed, the retinal surgery, they have to send the patients to tertiary eye care center in capital city and other parts of the country. There are several centers who can do the retina surgery, and most of them, our retina surgeons are being trained in India in LV Prasada Institute, in Arvind Eye Hospital, in Shankara Nethralaya. So they are taking care, they are making future generations who are taking care of these patients. But still, only 60 to 70 retina surgeons are there in the whole country who can do retina surgery. We have to increase this number in near future. Thank you.
Thank you. So next, I would like to ask Dr. Abdullah from Maldives. In your situation, in your country, is different. People live in remote area far away.
Yes.
How do you screen them? Do you use more of the telemedicine technology or something?
Now, as you know, the Maldives has got a lot of islands scattered in a vast area in the Indian Ocean. And the problem, as far as I see, is that we don't have any referral pathways well demarcated. And we have 3 levels of in the very small islands. We have health centers managed by a doctor, and also the secondary level we have atoll hospitals, most of which does not have ophthalmologists to manage the cases. And the tertiary center, as we have in Male in the Indira Gandhi Memorial Hospital, and recently they have started an ophthalmic center in the Hurumali Island, and also a private clinic which has got lasers in the capital. So now the thing is, many times referral is not at the desirable level. Now, we know that each patient, if we want to bring out a successful outcome for diabetes management, retinopathy management, it has to be accurately detected and treated at the optimal time. But that is not unfortunately happening, because many cases are not detected, and when it is detected, it is too late. And moreover, there is also an element of trust between the patients and the people who see them first. Now, in the peripheral level, people, you see, many people do not worry so much if they don't have pain. Now, diabetic retinopathy in the early stages is a painless condition. So even if that person is having a moderate level of retinopathy or severe retinopathy, there is a lot of communication gap sometimes between the doctor and the patients. So convincing the patient to travel to Male, I mean, they have to come by boat, and there are other issues also involved. Many times, some of these people are senior people in age. They cannot come alone. They have to come with another person. And we have another issue that coming and staying in the capital, Male, is very expensive these days. It is sometimes, some people say that it is more expensive to stay in our capital, Male, than going to a neighboring country. So that is another issue we are having. And the other things that I feel is that the another issue which we face is that it is very difficult to convince people to change their lifestyle, the habits, the food. So this is another issue which we face. You know, I have seen several patients with advanced cases of diabetes who never get controlled because they never listen to the doctor and control their diet. Very difficult to convince them. And we have a lack of dietitians in our country who can clearly explain this to the patients, which type of diets they can take. That part is severely lacking in our country. And since a large amount of people are becoming diabetic because of the difference in lifestyles and taking like what we call junk food, etc., and all this, there is a sort of lots of pre-diabetic people too, whom we can cater to, because these presentations are excellent, but it is mostly based on treatment. But if we want to tackle diabetes very well to the next 10 or 1 or 2 decades, prevention plays a very important role, and which is lacking very much in our country, because there is a window of opportunity to slow progression for pre-diabetic patients after they are diagnosed within the next 3 to 6 years. So what we see is that doctors are always the limited amount of doctors in the tertiary centers, and even in the secondary level, they are very busy and they do not have adequate time to explain the seriousness of this to the patients. So they take it very lightly and go on progressing. Ultimately, one fine day, the vision becomes very bad. And the other thing is regarding the treatment wise, we have a universal healthcare system where the government pays for it. It's covered to the whole population of the country. Treatment within the country and outside the country. If they are not treated in the Maldives, if a doctor refers them, they will be sent to a neighboring country too for treatment. But sometimes what happens is, because of this is another issue, that because of a lack of communication, proper communication, some people delay their treatment. They have all these stigmas, all of ideas about laser, and many people are reluctant to put an injection into the eye, the anti-VEGF. A lot of people I have seen, they go to 3-4 different doctors, get opinion from each one of them, and come and finally ask me to whether it should be done or not. And in that process, sometimes they waste a couple of months. So a lot of things are like that. So in our country, there should be, I feel, a much more comprehensive approach towards tackling diabetes in all fronts, training people, getting the finance, involved in the community leaders, involved in the politicians too is a very important part, because without involving them, we may not get funds, we may not get the required support. And like in some other countries, I think it is a good idea to even involve the religious leaders in a certain locality. They can also pass on the message, because the message is not going across to the people that retinopathy is a serious condition that can threaten your vision, and you may end up becoming disabled if you don't take proper precautions. So a lot of issues related to this, mostly related to prevention, which we face in our country. And regarding the other thing is, as I have said, we have got a lack of trained manpower. We do not at the moment have a full-fledged trained retinal surgeon in the country. Medical retina is tackled, fluorescein angiogram can be done in Male, as well as medical retina intravitreal injections can be given. So basically, in a nutshell, these are some of the issues which we face in our country. Thank you very much.
Yes, Dr. Abdullah, I think the keyword of your talk is comprehensive. When we do the public health program, as Dr. Padmaja has tell us before, we have to think of many issues, not just the technical medical issues, health education, prevention, and sometimes about financing or something are also important. Manpower issue is also important. Next, we have limited time. Would like to ask my friend, Dr. Paisan. I know you like technologies, and in our region, in some part, there are fundus camera here and there. The internet are there. How about using the telemedicine to screen diabetic retinopathy? And do you think we need people to do the screening, or can we use the AI for that? Can you give us some short comment for this?
Well, I think this is a very important question. I think geographically, there are many countries in our region. For example, Indonesia and the Philippines, that contain many islands, I think telemedicine would be very suitable for the conditions over there. And well, if you adding artificial intelligence, but I think the difference between artificial intelligence and the trained graders for grading is a consistent of grading. And we don't have to do a kind of continuing education for the trained human graders. AI is pretty consistent. And I think the accuracy of AI is quite very high now at the moment. So I think I should say yes. Well, there are some certain countries, India maybe as well, and maybe some other countries which have very large population and population that contain, live in many islands. Using them, using AI with the telemedicine would be a problem solving, I think. Thank you.
Okay, we have so limited time. I would like to touch a little bit on the treatment. By the time I graduate, the management of DR is laser, and for serious case, renal detachment, vitreous hemorrhage, we do the surgery. But this time there are several intravitreal injections. But for this kind of treatment, the patient needs to come in and in again and again for the treatment. For all the panelists, do you think how can we cope with the changing of the treatment technologies like this?
Yes, I would like to mention something here. Intravitreal injection, it is something that it's very difficult to convince people to go on getting it for 1 year or 2 years or 3 years more, because many people, they have got sort of this fear, the taboo that an injection is going inside the eye, because we have to explain it, everything, take their consent to give that and all that. And in our country, in the Maldives, people are very literate. It's about 95%, most of the islands, even in the capital. So even if a senior person does not know these things, the relatives who come with them are highly educated many times. So they ask us how many times this injection has to be given. So when we say that it depends on the outcome, many times they are not very happy. So they are reluctant to give it again. So then we have to explain, and sometimes some people come from very far-flung atolls. So the difficulty in bringing them for treatment with the relatives is there. And so I think we have to have a balanced approach regarding the intravitreal injection as well as the laser. So if we fear that the patient may not come back for follow-up, I think the laser will be far better than the injection, because that can give a one-time treatment which can last for a couple of years probably. But intravitreal injection, if we tell them to come after 3 months for the next injection, 6 months for the next injection, and there is no time limit, and it all depends on the outcome, they are very reluctant, and most do not want to continue after maybe 1 or 2 years. So because of the fear, because of the high cost of the injection, and because there is no time limit in which we will be stopping it, so this makes it very difficult. So I think in cases where such issues are there, when people, we do not get their cooperation, it is far better to give the laser for them, or maybe a combined laser with the injection. So it has to be individually tailor-made for the patient according to the clinical condition and according to their expectations, because without their cooperation, the treatment will not be successful, right? So that is the issues we face.
Agree. In my country, we select the intravitreal injection for the very compliant and understanding patients. How about in India? How the patient accept the injections?
Regarding India, I would like to say that once properly explained, many patients do go ahead with the injections, but the problem is a cost. And I think most of our agencies, say health agencies, even private as well as government sector, we should somehow work towards legitimizing the cheaper injections, because even these ones do have a good effect. And I think for a general population, unless we give them regulatory approval, the use will not increase too much in the private sector, perhaps because they have storage issues and other issues. Since those bevacizumab does not come in single dose vials. So I think that is one issue which we should look at, which unfortunately is being neglected. But other than that, I think we cannot go by the West and go ahead with monthly treatments or very frequent injections. We have to tailor make it to the individual patients. Even fewer injections do help. And like Dr. Abdullah said, it has to be a combination of injections followed by laser for the long term.
And for the serious disease like traction renal detachment or complex renal detachment, I think we need to help each other in the region in the manpower production. We need to produce more vitreoretinal surgeons. Do you agree? Yes.
Of course, of course. So, just 1 minute, I just want to tell one sentence about the intravitreal injection. That is, in my country, we are using bevacizumab, though it is not, it is government, it is not legalized, or even it is not unlegalized also, we can use. So we are using bevacizumab, and other injections are much higher, costlier than India even. Ranibizumab is much costlier than India. We don't get eccentrics and others. We have to get ranibizumab. So till now, I didn't face any case of endophthalmitis. Till now, may God bless me. But it can happen anytime, as you told that bevacizumab should not be used as because it is not single vial. But we are using. In the same time, what I want to point it out that there is injudicious use of bevacizumab also throughout the country by different surgeons, which patient doesn't need, we are putting injections to them also. That should be again monitored. That is my feeling. Thank you.
Well, Tariq, approved, can I have a permission?
Yes, please.
Well, Tariq, all over the world, 65% of people only receive bevacizumab, not ranibizumab or brolucizumab. So we don't have to worry about that. That so-called quote unquote off-label is only company created statement. Please don't worry for that, because intravitreal vancomycin panathymide is also off-label. It's not quoted anywhere else. So don't worry for those things at all. There is a company creation. If you can manage, if you can, patient can afford, definitely go for whatever is possible. Like Rohan told, that combination of laser and injection, like Dr. Abdullah also told, same thing is possible. Not have to worry too much about that. But what we also understand is, unfortunately, like when we complain that our endocrinologists do not refer the patient in the right time, I also find that we ophthalmologists do not insist on maintaining a good glucose level or A1C so that the injections will work better. Also imperative that diabetes, hypertension are also properly controlled. In India also anemia, by the way. So let us start working on that issue. Also, by the way, I think to my knowledge, by end of next year, 2022, you will have a single dose bevacizumab available to you. Single vial, use and throw it. Yeah. Yes, we are working on that. I am part of the whole group. So it should be available by end of coming year.
Yeah. Thank you. I think Professor Das has already summarized all the things for us. And another thing I would like to add is that to cope with the big problem like diabetic retinopathy, multidiscipline networking would help. We cannot do it alone in the ophthalmic sector. So I think we in the region will help each other and work with other healthcare personnel to help our people to get a better visual quality of life there. So last, I would like to thank all the speakers, all the panelists, and also the technical teams, and also IAPB and WHO to provide this webinar. And most of all, I would like to thank all the audience to be with us this afternoon. Thank you and goodbye.